Now I'd like to move on and welcome Florence Lustman. Florence, I think, is the driver behind President Sarkozy's commitment to dementia care, and Florence has been very active across Europe, spreading the good news of what has happened in France. So I'm delighted to welcome you here today.
Thank you very much for these introductory remarks. Ladies and gentlemen, it is a real pleasure for me to be here today in Dublin. I have read with great interest your outstanding contribution to what I hope will be the future national dementia strategy in Ireland. And I found a lot of similarities with our strategy in France. I also found, of course, a lot of similarities with the previous presentations, namely the Norwegian one and also the British one, which is, after all, not at all surprising. My purpose today is to tell you where we are after 4 years of implementation of our national strategy that was launched in February 2008. So, dear friend, you were the first ones. No competition on that. So that's absolutely clear for me. And at the end of this presentation, I will draw some lessons of these 4 years of implementation. And so far, I found 6 lessons to draw. So let's go back in the past. The past was the election of President Sarkozy. And I think France is very specific from that perspective. In most countries that I have visited, and typically your country today, but it reminds me also of a meeting we had in India, for example, the incentive generally comes from the ground, comes from the associations which provide excellent reports on the state of play of people with dementia in their own country. It was not at all the case in France. The incentive came directly from the highest political level, because it came from the president. And this commitment to dementia was part of the political program of Nicolas Sarkozy when he was still a candidate to the presidential election. So I think you have to keep this in mind because, maybe this will explain some differences between what I'm going to say and what previous speakers have presented. To stay in the past just for a couple of minutes, let me just remind you that this French strategy that maybe you have already heard of was not the first French Alzheimer strategy, and in fact it was the third one. And I think this is very important. We had 2 previous Alzheimer plans, and when Nicolas Sarkozy was elected, he immediately installed a commission chaired by Professor Joël Ménard, involving more than 100 people, specialists of all the fields of Alzheimer and dementia. And their conclusion was that there was still a lot to be done in order to increase the quality of life of patients and carers. And this in spite of the 2 previous Alzheimer plans. And the reason for that is that the 2 previous plans were mainly health plans. They were health focused. There was a very interesting question some minutes ago. Is a person with dementia, is it a patient, is it a person? Definitely it is a patient, but it is also, and maybe mainly, I don't know if I'm also right to say so, but my conviction, if you stress too much the view that this person is a patient, then you miss a lot of dimensions in the treatment and the care for these people, and that you cannot increase significantly their quality of life. This was the statement of the commission chaired by Professor Joël Ménard. Then this beautiful strategy was issued and launched A lot of money was promised, and the money is available. It is more than 1.6 billion euros for 5 years. But it is one of my missions to tell to the president how much is spent really year after year on this strategy. And thanks God, not all the money is spent. And after 4 years, we have spent something like 400 million euros out of 1.6 billion euros. So my message, and Alistair repeated that several times this morning, you do not need so much money to do some very beautiful things in order to increase the quality of life of patients and carers. What was new in the third strategy was the direct implication of President Sarkozy, of course. I had been appointed directly by him in order to assess the implementation of this strategy on a day-to-day basis. And I personally report to the President directly every 6 months. This is very, very important, of course, and it's one of the key success factors, I think, for the pilots to continue to implement, because I completely agree with my Norwegian colleague. It is tremendously difficult to make things change in real life for people with dementia. Well, everything that is done under this strategy is available on our website. Part and only part of it has been translated into English. I'm very sorry for that, but the strategy itself is translated. And all the surveys, the in-depth surveys that we made on in general population, but also among carers, among family carers, among professional carers, among patients, among people with dementia themselves also, all this has been translated into English if you're interested. When I have just 5 minutes or 2 minutes to make a presentation of the strategies, this is a slide that I'm using. Because everything is in this slide. First, the fact that our strategy is totally global, with 3 main objectives. The first one is to cure. This is pretty new in France, and once again I come back to your comment, my Norwegian colleague. When the Commission, chaired by Joël Ménard, imagined this strategy, they did not know if it was necessary to fund French research on dementia, because at this point of time, France was not among the best countries in the world for research on dementia. So there was a decision, and the decision finally was made to fund research on dementia in France, but there were some discussions on that point. The second objective is to take care of the people, and it's the people with dementia together with the carers. And this aspect crystallizes the main financial commitment of the strategy, and perhaps also the greatest difficulties in practical implementation. And the third objective, it's very important to us, and maybe I think it's quite singular to our national strategy. We have put at the same level as the 2 first objectives, as you can see, the respect, the ethical dimension, and the fact that we should guarantee the dignity of the person with Alzheimer's all along his or her life. This societal and ethical aspect is, to our view, very important. It is also very important for practical reasons. You know that these families suffer from stigmatization, and this is still the case, I'm afraid to say so, in France today, despite all our efforts. And there are some very practical consequences of the stigmatization. One of it being the fact that the GPs are sometimes very reluctant to announce or even to make the diagnosis of Alzheimer for their patients, because they do believe that after that, life will be still more difficult for them after than before. Of course, they are absolutely wrong. But you know, if you do not change the view of society on these families, on these people, then you have that sort of backlash consequence. So let us go through these through objectives and see where we are now after 4 years of implementation. We are currently funding 125 research projects for a little less than 100 million euros. And by the way, I wanted to make a comment regarding the comparison that is made very often between the funding devoted to dementia research and the funding which is devoted to cancer or other diseases. Just to say that we had some money, we had a lot of money regarding the budget of research in France for dementia, and yet for the first 2 or 3 years of this strategy, we were lacking excellent research projects. So I think the fight is not to say that you need more money, you don't need more money, you need more researchers. So you need to attract new researchers on this discipline if you are lacking such researchers in your country. And after that, maybe if they produce excellent projects, then maybe you will need some more money. But I can tell you, for example, for clinical research, even in the fourth year of our strategy, we do not spend all the money that is available for the funding of clinical research. And it's only because we are lacking excellent projects which are selected by an international committee of persons that are the scientific commission of our foundation. So just keep in mind that you cannot go up that way in the budget of research. You need the staff, you need the researchers. I think what is important is that we have invested in a number of structural measures in order to increase our research capacity. We are currently funding and implementing a national epidemiologic data bank, and we have had recently exchanges with our Dutch colleagues who were very interested in that experiment. Typically, this consists in registering systematically the same sort of information on all the patients that go to the memory clinics. We are funding cohorts for research, including a cohort of young patients. And we are also funding an imaging center to standardize all the MRI, for example, that are currently done in France and that until now were not very useful for research because each memory clinic was doing their own sort of MRI and thus was not comparable with the MRI of the next memory clinic. So this is clearly, I think, quite a clever investment. We are funding all dimensions of research with a special comment on, yes, this one, human and social research. So I would be eager to have your feedback, the feedback from my colleagues who also have dementia strategies. I said so at the beginning of our strategy, and I'm afraid I still have to make the same comment. We are lacking social science researchers to work on non-pharmaceutical therapy, for example. And I know that other countries are more developed in that field. For example, regarding rehabilitation, we took notice of publications of a Dutch publication and a UK publication. But in France, we really have difficulties to attract human and social sciences researchers on dementia, and that's a pity because it's very important. Well, I think France had a definite impact on this decision that was made by the European Union in 2008, just because we were chairing the European Union during the second semester of 2008. And we took this opportunity to launch a number of programs. So they are called in the European jargon joint programming. You can have joint programming in research, which is the case here, with now more than 23 European countries joining their efforts in order to boost the results of research on dementia. But you can also have joint actions on epidemiology and exchange of good practices. And we are currently having another joint action, which is led by the French Health Agency. And one of their major features is to exchange information on the prescription of antipsychotics for people with dementia. So I think this is very positive. This is nationally funded. These programs do not benefit from European money, but after all, European money is our money anyway. And it's based on a voluntary basis, so it's more soft and easier to implement compared to the huge European programs. So this is very effective. Let's move now to the third objective being to change the view of society, both nationally and internationally, on Alzheimer. This is organized partially around a specific ethical commission that was created specifically in the course of this strategy, and they are organizing a series of conferences, sometimes international, sometimes national, but also some very local conferences in the nursing homes, for example. And I think the cost of such actions in the nursing homes is close to zero, and yet the impact is very important, because then the staff takes 1 or 2 hours just to think about something else and of the ethics and what does the person with the dementia need in the course of the life in the nursing home. So, I mean, you always need to have some big international meetings such as this one to exchange good practices, but let us not forget that you also need some very practical actions on the field, let's say. And I must say that in the course of this third objective, we have implemented a series of surveys also. For me, this goes with the fact that you always have to stick to the needs of the person with dementia and the needs of the carer. But what are these needs? And that's the reason why we implemented these huge surveys. And one of the results of the surveys, but we have many of them and are very, very interesting, so that's the reason why I encourage you to go to our website. But the one that I will keep in mind is the fact that more than 90% in general population of the French citizens have said that if they have symptoms, they want to have access to their diagnosis, even if it is a diagnosis of Alzheimer's disease. This is very important. You know, as far as communication is concerned, I think you need to select some messages, and for me, this is definitely one of the key messages. It is also one of your priorities in the UK strategy. Unfortunately, in France, we still have a number of people and a number of GPs who continue to believe that it's not necessary to announce the diagnosis, but this is not respectful of the will of the persons, and this is what these surveys show. So, no, sorry. Let us move now to the second objective. The second objective is to implement a personal and tailored pathway for a person with dementia. And the objective is to have this pathway available for all French citizens with dementia by the end of 2012. I can already tell you that, very unfortunately, we will not be able to meet that goal. and that we will need another 2 or 3 years, depending on these measures, to meet the goal. Yet, what was our objective? First thing, it is to deal not only with the person with dementia, but to deal also with the family carer and to deal together. And that was not the case, for example, in our 2 first strategies in France. And then, regarding the diagnosis, in fact, in our strategy, initially, we did not mention the GP. Because in France, a diagnosis is made by specialists. The GP is not allowed to make the diagnosis, so the strategy mentioned only the specialists. And in France, we have quite a beautiful network of memory clinics all on the territory. So as you can see, it is pretty easy to get a diagnosis on our territory. It is even easy to get a diagnosis for our young patients because we had developed a specific center for them with correspondents deployed all over the territory. So you could believe that everything is perfect, and everything was not at all perfect. And why? Just because the GP do not send the persons, the potential patients, towards the memory clinics. So 2 years ago, I suggested to our president to have a special focus on the GP and try to understand the reason why the GPs were so much reluctant to send their patients or potential patients towards the memory clinics. And this has taken 2 years because, at least in France, relationships with the GPs are very, very complicated. But yet, something has come out of all these discussions, and we are in the process of implementing an annual visit at home by the GP, which is reimbursed because all this is funded by our national welfare security system. So it's a double consultation, and the GP will go at home in order to assess in their own environment both the health of the person with dementia and the health of the carer. And, you know, this has been absolutely key to the involvement of the GPs in the process. So far, GPs said, okay, dementia in France is a disease for specialists. It's not for us because we are not allowed to make the diagnosis. We are not allowed to make the first prescription of drugs. So this is not for us. And this is the way our system has managed to put the GP back in the system. We will have these first annual visits in 1 or 2 months, so it's too early to assess the efficiency of this decision, but at least the GPs have agreed to come back to the table and to talk about the dementia. For me, it's already a very interesting result. Well, so that was just the point of diagnosis, and I think it's very clear in your documents that it's not only to make the diagnosis, it's not only to announce the diagnosis, but once you have announced, then what do you do? So what do you do in order to help the persons with their future? And the answer that we have imagined in France, and I think that might be interesting regarding your couple of, I don't know how you call them, the 2 persons who are supposed to, the special team or whatever. So we also have this concept of saying that some people should take care of these family very specifically, but our answer is pretty different. Our answer is the following. We believe that the challenge was mainly to put an end to the chaos for families who do not know where to go and who to contact when they have this burden of Alzheimer. And we have in France a plethora of poorly coordinated and compartmentalized systems. So the real challenge was to make all these people first know each other, because in France, doctors in hospital won't talk to social workers. They won't even talk easily to doctors in the community, for example, or to GPs. So the challenge was first to put all these people around the same table. Second, to give them tools in order to exchange information. And only third, to implement case managers. But the case managers, our experience is that they are not very effective if they cannot work on the basis of this network. And the idea of this network is that whatever the door where you are going to knock, you will get the same answer. The answer being, okay, great, you have knocked at the right door, so you stay here and I will provide the adequate service for you. But it can also be, which is the most frequent, no, I'm sorry, but for you at this stage of the disease and regarding your whole global situation, you'd better go to this service provider, and I will send you to this other service provider, and you won't need another assessment because we will share the assessment, which was not at all the case in the past. So for us, you need both. You need this network, which is really challenging to build, and our experience, because now we have more than 50 of these networks currently working. Once you have the network, you need case managers only for what we call the complex cases. The complexity being not only linked to the disease or to the level of the disease, but also to the social situation or to the family situation of the person. And well, we don't have the precise percentage, but somewhere around 70% of the families are taken care, I would say, naturally, just by the organization, and in 30%, then you need the intervention of a case manager. But this takes time, and typically, I think for me, this is the most innovative and the most adequate organization of all our strategy. Of course, it is efficient not only for people with dementia, but also for any elderly person. The thing is, it takes time. It takes at least 6 to 9 months to build this network and to make really people know each other, respect each other, and share common tools. That's the reason why the objective, which is to have Mayas available on all the territory, which amounts at roughly 500 Mayas, will be reached somewhere between 2013 and 2014, because this takes a lot of time, and they need the help of a pilot. I mean, this is not natural at all. People will tell you that they already know each other, they work together, but in fact, it's not at all the case. So you need a specific manager. We call him or her a pilot. You put the pilot for 6 or 9 months, and then you can start with the case managers. This is once again the most effective measure of our strategy, to my view. And this structure is going to interact with the family and with the GP during all the remaining life of the person with dementia. So they will be in touch with the GP, so the GP will stay in charge of the health aspect, but he will be working with the people of the Maya, with the social worker, and it is also an organization which is very comfortable for the GP, because the GP does not need to care for all these social services anymore, which was something that he tried to do in the past, but of course, generally he failed because the GPs are not used to social organizations. And then we deployed a series of very specific solutions. For example, rehabilitation, which I think you call occupational therapy. This has proved to be very effective and maybe as effective as drugs for 6 to 9 months. So we found that sort of service for people with dementia. We have developed respite and support platforms for carers. And out of home, we have developed special units in hospitals and nursing home. But of course, all this is linked to the availability of trained professionals. And I'm very much surprised in your assessment, you have said that was the easy part of it, to train the staff, while in France we had tremendous difficulties to implement this training for staff, and it took at least 3 years to open new seats in these schools for occupational therapists in particular. So, but now we've managed to start the engine, as I would say. But for us, it has been a real difficulty in the implementation of the measures. And maybe last one remark regarding this slide. In the nursing home, and maybe that's an alternative to what you have shown, which is very convincing, these special units entirely dedicated to demented people. In France, the choice that we have made, based on a full review of research on these topics, is special units within the nursing homes, so nursing homes with people with dementia and with people without dementia, special units for people with behavioral troubles. Because, in fact, the analysis that we made was the following. A number of nursing homes in France refuse the people with dementia. And the reason why they refuse these people is that they don't know how to cope with the behavioral troubles. So it creates problems not only for the people with dementia, but for all the other residents. So the easy answer, which is not a good answer from a political point of view, is we don't take these people. And the solution is to have some sort of internal daycare center with a very specific architecture, with occupational therapists being able to deal with these people. And every morning, the staff of the nursing home will say, okay, today this and that people, apparently they're going to have behavioral troubles today, so we will send them to our internal daycare center. And we have, I think, 300 of these units currently available in France. And the statistics show that, for example, the prescription of antipsychotics has drawn back to zero nearly, that these people, they sleep at night, because one of the difficulties in the nursing home is that the people with dementia, they walk at night, they don't sleep. But when they spend the day in this special unit, then they can go back. So their room stays among the other rooms, so they don't have to move elsewhere. But it's some sort of daycare therapy when needed. I think I'm close to the end, so this was just to show you where we are in the development of the daycare centers. So there are pretty large differences on the territory, some territories being much more dynamic than others, even if all this is fully funded by our national strategy. So that's the reason why I keep saying it's no matter of money, it's a matter of available projects and local dynamic. This is also the development of our occupational therapist and occupational therapy teams on the territory. Is that okay? And we are following this indicator because we have indicators on each of the 44 measures of our strategy, but in the end, you have to find some of them which make sense and on which you can communicate, we made the choice of this prescription of neuroleptics. We started at nearly 17%, and in 2010 we were still at 15.5%. The objective is 5%. We are still very far from that. I'm very keen on the result of the UK strategy because they decided within, I think, 6 or 9 months to divide by 3 this percentage of prescription of neuroleptics. Just to let you know that in this specific daycare, internal daycare centers in the nursing home, you can decrease nearly to 0. In the territories covered by the MAIAs, we have the same observation that the prescription of neuroleptics decreases significantly, and this indicator is in the process of becoming a European indicator, and I think this is very positive. So, as a conclusion, I told you that I had a number of lessons that I could draw at this point of time of the development of our strategy. Whoops. Okay. Well, the first lesson that was a lesson drawn by the Commission, Joël Ménard, is that Alzheimer is not only a disease, and by far. Second, the objective must be to reach an earlier diagnosis for all our citizens. Third, providing large access to diagnosis is not sufficient. You need to involve all the primary care system, namely the GPs in our country. Fourth lesson, money is not the limit. It is the availability of good projects. 5, you need some simple and global indicators. So the one that we have chosen is a prescription of neuroleptics. And 6, the lesson is humility. Dementia is a complex topic. It is complex scientifically speaking because very unfortunately, and despite all the money that we put on the table, and not only France but the US and everywhere in the world, I'm afraid that we are still very far from having a drug treatment tomorrow morning. It is medically complex because I understand that posing the diagnosis is not so easy, and it is socially complex. So all this is definitely a lesson of humility, and in front of that, I think that we must all benefit from cross-fertilization. As I said, occupational therapist in our strategy is something that we have copied from the Dutchland and the UK, and I'm very proud to say so. Thank you.